Hi everyone who is already connected. Welcome. Good afternoon for the people from this side of the world. Good morning for the people from the other side of the world. Ciao Sergio.
Ciao Lorenzo.
How are you doing?
Super good. Ready to start.
Even in Domodossola, the weather is not good.
Cloudy, rainy, really bad one.
Same in Milan. Very bad, very bad.
Next time we do an open air webinar with better weather
condition. It would be a great idea. So, welcome to all our attendees. I see some friends here. We are already connected. You want to say something, Sergio?
Guys, write to us. Use the chat to give us suggestions, comments. Just write there where you're connecting from, your name. Give us some information.
What's the weather like? Where do you live?
How many millimeters per hour of rain?
Or if you have the sunshine, just don't write, because otherwise we will be even more depressed. But anyway, I start recording this webinar, so welcome everyone. Oh, I see someone is writing in the chat. Claudia, bom dia. Falamos poquito de português, no. No falo português, no. So today, guys, we are gonna go through the summary chart, similar to the one that we've seen some weeks ago. But today we are going to see the Venus indications, so the summary chart about the Venus indications. The objective of this webinar is to have a clear idea when it's done to whatever we need to do and we need to remember to support a successful case, a successful Venus case, tips and tricks. So please, all the doubts need to be cleared out. If I'm not explaining properly, just stop me, just write in the chat. Sergio will be following you in the chat for this time, so please make questions. Let's keep it interactive. Stop me, then Sergio can explain a better way than I did, or we can, if you have any doubt really regarding some points, please ask, and we will try to explain as much as possible in order to clear every doubt. So I would start with a presentation now, and here we are with our chart. Similar to
Lorenzo, just a second. Hello, Claudia. Hello, Valdo. We have many guys connected here. Just to say, if you feel more comfortable to, write questions in your own language, we are able to translate. How many language, Lorenzo? I would say 75, 76.
The only one that I don't speak so much is Nepalese.
Okay. And only some dialects.
And I think that's it.
Okay, but probably Google Translator may help us. So feel free to ask questions in whatever languages. We will try to make our best.
Exactly. Okay. And then if you want the recording of this webinar, if you have further questions that are arising after when we are done, or if you want the chart, just write to webinar@straubmedical.com, our email address. You can also reach out to your area sales manager. We will be happy to be in contact with you if you have a further question, further request from your side. You can also, guys, suggest some topics to us to go through for the next webinars going on. We are here to help you as much as we can. So here, guys, we have our chart, and it's similar, as you can see, from the arterial one that we went through 3-4 weeks ago. I don't remember exactly, together with you. On the right, we have the general tips and tricks regarding Aspirex. And let's start from this, and then we go through the main table here in the middle of the chart. So first of all, when we are talking about Aspirex, we know that we are talking about a device which is effective on acute material. So Aspirex is not indicated for chronic material. Why? This is really important to remember, and we need to try to understand why it's effective only on acute material. When we are comparing Aspirex with Rotarex, we know that Rotarex has 4 main functions, which are detachment that we can achieve thanks to the facets that we have on the rotating head of the catheter. We have fragmentation, we have aspiration and transportation. Fragmentation in Rotarex catheter is achieved thanks to the spinning head that we have, which is spinning 1000 rounds per second together with the helix, creating a vortex. This vortex is fragmenting all the material. Plus, if you see here, we have inner blades in the Rotarex. They are inside, they're not touching the vessel wall, but these blades helps in breaking in smaller particles the thrombus that we are taking out from the occlusion. This is why the fragmentation of Rotarex is really powerful, and we can treat acute, subacute, and chronic occlusions. Aspiration and transportation are achieved thanks to the helix spinning 1000 rounds per second, fixed aspiration and fixed transportation. We know that every catheter size has a fixed aspiration power, 45 ml per minute for the 6 French, 75 for the 8 French, 130 ml per minute for the 10 French. It's there. When we are looking at Aspirex, we still have fragmentation, aspiration, and transportation. We don't have detachment anymore. We don't have the facets, and the head is not spinning. Let's skip fragmentation for a second and let's go to aspiration and transportation. Aspiration and transportation are exactly the same as before, as Rotarex. Why? Because it's given by the helix. So the 10 French Aspirex has the same aspiration power and the same transportation effect of the 10 French Rotarex. No differences. Where is the big difference? In the fragmentation. The head is not spinning. As you can see, we have no sharp blades inside. So the fragmentation is achieved by the helix rotating, not the head, no vortex, no sharp blades. You understand that in this way, powerful than what we see in Rotarex. So this is why Aspirex is effective on acute material. And also the thrombus that is taken out with Aspirex usually is a little bit bigger in bigger pieces than with Rotarex. But what does it mean, an acute occlusion? So Sergio, do we have a poll for this slide for the guys? I cannot hear you. You're muted.
Oops. First of all, ciao Umit.
Ciao
nice
Umit.
Ciao Sergio. Ciao Lorenzo.
And actually, let me make this poll ready in a few seconds.
Or if you want, we can also ask our audience to answer through the chat. The question here is, in your opinion, which among these three angiogram that you see is the angiographic images that you see is the most acute? Okay, most acute of these images. I will leave some moments. Please write in the chat. Sergio will read the answers.
But we are super fast. I mean, we can already launch the poll.
Ah, perfect. Come on. Here, the level is really, really high. So, okay, guys. So here you can see the poll, which is the most acute left, center, or right image. And we know that when we are looking at an angiogram, we can.
So I think there is some issue with the connection, but since we are, interchangeable,
look for some.
We lost you for a while,
okay,
Lorenzo.
But
start from the explanation of the first image, I would say.
Okay. Can you now? You can see me properly. I'm not freezing.
Yes.
Okay. Very good. So when we are looking at the images, we can look for something that tells us a story. When I'm looking for an image, in order to understand if I'm looking to a chronic occlusion, I will search for collaterals. We know that body responds when we have an occlusion, creating new vessels, collaterals, in order to bring blood up back to the heart in this situation. So if I look at an image and I don't see big collaterals or many collaterals, it means that still we are in a fresh acute occlusion, as the body hasn't developed yet a good network of collaterals. Then, when I'm looking to a fresh occlusion, acute occlusion, what I expect is something like the the one on the left, which is the most acute among these three images. So this marble-like aspect of the occlusion. Why? Because, you know, when you have fresh thrombus, fresh material, still it's not so compact, so hard, and so the contrast is anyway finding some ways to go up. As you can see here, we have contrast here, start of the occlusion, but then contrast is going up. So it's more or less like looking at some, you know, the marble stone with this aspect. And here I don't see big collaterals. In the center, as you can see this image, what I can see is that we have one big collateral. Occlusion here, this vessel is a one very well-developed collateral. Nevertheless, you can see that here the occlusion is different from what we've seen before. I don't see any contrast going through the thrombotic material, but I can still see that here we have a round shape start of the occlusion, which is a sign of some not so fresh, but still not chronic material. So we are probably in a subacute subset, in a subacute scenario in this situation. Looking at the third image here, first of all, I see very well-developed collaterals here on the left. And then look at here again, we don't see any contrast traveling through the contrast. And the beginning of the occlusion has a sharp edge, not rounded like here. This is a sign of a more chronic material. Do you agree, Sergio?
I agree, and also our audience does. I mean, they have 100% of correct answer. Also, Natalie in the chat. Ciao, Natalie. Nice seeing you. And so, perfect. Also, well described. Thank you.
Okay, very good. So, here is what we want to see. Do you want to add some?
Just, you know, for our audience, if they still have some doubt about how to, you know, distinguish these images, or they have any doubts, any question, please don't be afraid. Just communicate with us, and Lorenzo, we will answer to you.
At least I will try. Going back to our chart here, second point, we know that we are working in the venous system. We know that venous system means almost zero pressure, 0 millimeters of mercury of blood pressure, low flow because of that. So anytime we are using an Aspirex, we want to give an infusion through the side port of the introducer sheath. And we are going to see which kind of infusion. Please keep in mind that in order to provide the correct amount of infusion to the catheter, we want to upsize the introducer sheath at least 1 French in order to have some space for the infusion to travel to the head of the catheter. And having there a long introducer sheath can be very important in order to push the introducer sheath together with the catheter to work very closely to the catheter head in order to provide the amount of fluid which is necessary. And if we have some collaterals, in order to exclude these collaterals so that we are not giving contrast to the patient in a systemic way. Everything will be aspirated from the tip of the catheter. So how can we create this infusion? We take a bag of saline, we empty half of that, and we replace saline taken out with a contrast. So it's usually a 50-50 mix between saline and contrast. Then we add 5,000 units of heparin, and this is our bag that we put in a pressure cuff connected to the side port of introducer sheath. Keep in mind that these 5,000 units, they are not adding anything to the patient systemic heparinization. We are going through heparinization in the next point. So this doesn't count. It's just here, they're staying here. And then, you know, having this mix, it allows us, let's see this video, to work seeing what we are doing. This is the really important part. See how this thrombotic material is aspirated by the Aspirex. We are moving upwards when we see that the vein is collapsing a little bit, like here, no contrast, we go back and we give time to the infusion to fill again the vein is well open, and we can start advancing again with the Aspirex. How do you know what to do when we see the collapsing vein on the catheter? It means that we don't have enough fluid there. We know that usually In an iliofemoral DVT, we use the 10 French catheter, 130 ml per minute. So if we don't provide the right amount of fluids to the head of the catheter, we can have.
And now you are freeze, Lorenzo. I think Lorenzo was saying that you may have the walls of the vein collapsing. So we really need to provide this amount of flow from the side port of the introducer sheath so that we can have the correct amount of fluids to be aspirated from the catheter. Now, a question for you, guys. We know that, we are aspirating all the material we are infusing inside the patient, provided that we can give the right amount of flow, the right amount of drops from the IV line. My question for you, and then Lorenzo can go back with his presentation. Did you have problems, making our doctor accept this infusion mix? I mean, all the doctors were putting without any issue the amount of contrast we suggest in the infusion mix, or you had troubles to explain that none of this infusion is going systemic in the patient? This is just for us to understand if your doctors are okay with this infusion mix or they made some trouble. Hi, Lorenzo. You went away for a while. I think Milan is full of people having Zoom today.
No, everyone is playing PlayStation, FIFA online, and so everyone is taking out the bandwidth from us. Let's try to see if I can stay with you. Otherwise, I will pass the word to Sergio, and so my job is done for today.
And what about you, Umit? Did you have issues in letting your doctors accepting the infusion mix, or not really?
Actually, we also, as like you, prepared this kind of solutions, contrast media and saline. But heparin used by the anesthesiologists.
Okay. But it's okay. I would say that if we don't put, all the 5,000 units of heparin in this mix, won't change so much, I would say. Would you agree?
Strange things. Some of doctors prefer to the DVT case with Aspirex. They prefer the general anesthesia, under the general anesthesia.
Yeah. Here we have Paolo saying that doctors normally, it depends from doctors, so it really depends. And Natalie is saying that only once she had a problem because the doctor didn't understand the value of injecting contrast in the veins, which is probably our experience as well. We need to try to convince them that it will not have a systemic effect. Over if you are using a long introducer sheath, which will allow you to inject this contrast right before the catheter head, but still I agree entirely with you guys. In some case, it's not easy to convince our doctors of this protocol.
Yeah, and sometimes, we can also balance a little bit, having, 60-40, 70-30. At least we can work. It's not the perfect case, but maybe we can convince them putting a little bit less contrast. Again, if we work properly, it's better to explain them that no contrast is going anywhere. We work really 5 centimeters far from the catheter head. We exclude all the collaterals, so nothing is going systemically, and so everything will be aspirated from the catheter itself. So not a big issue. But
thank you also to Claudia for her comments.
Great. Okay. I hope that I can stay with you for the rest of the presentation. So, third point, we anticipated a little bit this topic. It's really important. We know that our catheters, both Rotarex and Aspirex, they work properly with a proper heparinization. It means that the ACT measured is more than 250 seconds. So having the ACT machine in the cath lab, in the OR, in the theater, it's always a good point. We can check it. even more than once at the beginning when they give the amount of heparin. And then remember that after 45 minutes, the heparin effect is going down. So usually we need to give half of the initial bolus to keep the effect of heparin at level. And remember, there is no clinical reason to give more heparin. So no clinical reason, it means nothing to the patient. We are not causing hemolysis. We are not damaging red cells in the patient. But nevertheless, we have an helix, which is running 1,000 rounds per second. It can be 110, 135 centimeter long. And we have red cells and thrombus inside spinning very fast, going the collecting back. We want to avoid blocking the catheter, interaction and friction between the guide wire and the helix because of this thrombotic material inside. It's really important. We don't have the ACT machine because it's not possible to have it every time in the cath lab. We know that our guidelines tells to give at least 100 units of heparin per kilo of the patient, so a little bit more. My suggestion is it's important to discuss this topic maybe some days before the case, at least not in the cath lab, not in the moment we're doing the procedure, because it's always difficult to have a discussion about this topic with the doctor. Meanwhile, he's working and is ready to go with Aspirex or Rotex. So it's better to prevent a potential discussion there and to prepare the doctor to give a little bit more of heparin. Then, of course, we know that we never activate Aspirex without the guide wire completely in position through all the length of the helix, especially with big catheters. And we know, again, that the most commonly used catheter for Aspirex is the 10 French, as the iliofemoral DVT is our main indication. If you run and activate the catheter without the guide wire, you can have a broken guide wire. The helix will wrap on itself really easy, just a few seconds and it's done. Sometimes with a small catheter like the 6 French, you can get away with it, even if I'm not suggesting to do it. With the 10 French, 100% you will have a broken catheter. So be sure that the guide wire is running all along the helix, going out from the silver pin that we have at the end of the catheter. And of course, when you are ready to start, use our guide wire, the 1901 that we provide with the set. You can cross the guide wire using whatever you want, we know, but then exchange the guide wire. 1901 guide wire doesn't kink. We don't have a potential friction between the helix and the guide wire itself. Where to place the guide wire? I think that especially in venous cases, it's important to know where to leave the guide wire in order to avoid adverse events. So the rule of the 10-15 centimeter far away from the distal occlusion that we need to clean, to work in, it's always valid, same for Rotarex. But we can have some more aspects in the venous side. Imagine that we have an IVC filter in the inferior vena cava. We need to be sure that the tip of the guide wire is far away from the IVC filter. We can cross it without any problem, but we don't need to leave it close. Otherwise, we can damage the filter or the guide wire itself. We don't want to put the guide wire the tip close to the atrium, of course. So one suggestion is to put the guide wire in the right subclavian vein. It's in a safe place. Of course, do not leave there with a looped tip. Otherwise, if for any reason we have the guide wire starting spinning because of the interaction with the guide wire, we can damage the vessel, we can damage the tip of the guide wire. Straight there usually is the safest place to place the guide wire in a venous procedure when we are doing an iliofemoral DVT treatment. Of course, here, your best friend is the second operator. It needs to be trained properly in order to secure the guide wire and to be sure that it's not moving together with the catheter. We want to keep it steady and stable without any movement. Of course, when we need to choose the catheter size, we choose it upon the target vessel diameter. So the 6 French, we know that we can treat from 3 to 5 millimeter, the 8 French from 5 to 8, and the 10 French from 7 to 12. Okay. Veins, we know, especially when we are treating acute occlusion, veins are bigger than arteries, and so sometimes even the 10 French catheter, it's not big enough to to clean everything from the vessel wall, because the vein is big. So we have some tips and tricks for this. One is the talk technique. And if you agree, I will leave the word to our good friend, Dr. Bruno Freitas, which is explaining very clearly what is the talk technique.
To show you something, the vein is way bigger than the device. Sometimes you cannot aspirate on a good quality. Something you can do, I don't know if you can watch out, you can press the guide wire so that you can move the tip to the left and to the right, and then you can have more contact with the device itself, between the device and the wall. I don't know if you're able to see here.
So here it's really very well explained by Dr. Bruno Freitas. He's pushing the guide wire from outside in a gentle way. And you can see here that the Aspirex is moving right and left. So we can touch more material and touch more area, surface area. This morning, Sergio was pointing out a very important thing. If the guide wire is placed too close to the catheter head, it means that we have just, let's say 10 centimeters, which is the distance that we recommend to place the guide wire. Even if you push from outside, you don't have enough support for the guide wire to move a bulky catheter like it is Aspirex, especially a big one, the 10 French. So maybe you push from outside, but the catheter is not moving and we are not effective. So in order to be effective and to see this great range of movement that you see that you've seen in the video here, the guide wire needs to be placed the tip very far away. So for example, on subclavian vein, in this situation, we have a big support from the guide wire, which is able to move the catheter itself. Okay, so this is also another reason to place the guide wire there, in order to be sure that the support of the guide wire is enough to do also this technique, the talk technique. And here I think that in this image it's really nice to see how Dr. Bruno Freitas is cleaning with Aspirex. We have the occlusion, we advance, we aspirate everything, and we have the contrast going up and filling the vein in a proper way. What to do? We can also use a curved length introducer sheath, so we can direct the catheter, turning the introducer sheath, and then of course, slower we go, more time we give to the catheter to take out the material, so there is no rush. We have no rush in moving up too fast. Give the time to the catheter to clean everything. There is another aspect that is really important in Aspirex cases. As we know, the head of the Aspirex is not rotating. So we have the fixed windows that are pointing in one direction, okay, 180 degrees. If we just advance the catheter in this way, we just clean half of the vessel, let's say the vessel area. So it's always important to remember to advance the catheter, giving a rotation to the catheter itself from outside, a 90-degree rotation, okay, in order to be effective on a 360-degree way. And again, I will leave the word to Dr. Bruno Freitas, who is explaining this point very precisely.
You're able to see my right hand, but on my upwards position. With my left hand, we need to remember that Aspirex tip does not rotate. The head does not rotate together with the device. So I am rotating the device, as you can see, to the left, to the right, on a 360-degree basis. And if you watch, if we can look, I hope the image is okay. If we can look to the screen, we will be able to see that we already cleaned a lot of stuff. I would say that the vein looks pretty much different.
So Sergio, I would like to hear from you guys. Looking at an image like this, are we happy about what we are seeing or not? I mean, the result that we are seeing, I think it's really impressive. We can see a big vein, a smooth one, with a very nice, also aesthetic result, right?
Yeah. What do you think, Kumit?
Yeah, exactly. Fantastic. The large lumen with Aspirex is cleaning it totally. It's really nice.
Actually, it's not always like this, Lorenzo. Actually, doing this case, which probably, is what we normally should try to have in the cath lab. We know that the sooner, the better. If we are able to bring our patients in the cath lab after, I would say, 2, 3 days, 4 days after the episode, after the symptoms appears, probably this is the kind of situation we would expect. So we would expect, first of all, if a patient is acute, you said it, that marble effect in the thrombus, where the contrast mix a little bit with the material, and you can have that gray scales in the thrombus. Big veins, so very big and large vein. So let's remember, guys, if you have an acute occlusion, the veins will become bigger, and actually you will have that aspect also, for example, in the CT scan. So always, if we have to treat a DVT patient, if you have a CT scan available, this will help you to understand if the disease is really acute or maybe subacute to chronic. But Lorenzo, even though we don't have this very nice aspect, what do you think is the most important part, when we make our final control?
Yes, and it's the speed of the contrast that we see. Yesterday, we had a very nice webinar with Dr. Bruno Freitas again and with Dr. Migliara. We were talking about acute DVTs, but also chronic DVTs. And the take-home message, I think it was really important, is that what we need to provide is a good inflow and a good outflow, always together, because both of them, they are providing a good speed of the flow. If we are not solving the problem at the outflow, which usually is a mid-turner compression or something which is the origin of the occlusion, we can also take out all the occlusive material. So we will have a good inflow, but we are not having a good outflow, and probably we will have an occlusion in few weeks or maybe some months, but the patient will go back potentially with another DVT. And this is complicating, of course, the treatment, because the DVT can be a little bit more chronic and so more complicated.
Yeah.
So, yeah.
We have another very, very good question from our audience. So the question is, with this talk technique, is there any risk of damaging the walls, the venous walls, by having the windows of the catheter attaching to the vessel wall? And actually, I think this is one of the most important advantages that we have if we compare our device with a front sucking device, for example. Front sucking device, like, for example, Penumbra. This is a front sucking device. If you put the head of the catheter on the venous wall, you will have the aspiration of this venous wall. Actually, Aspirex is designed in a slightly different way. The windows are placed 180 degrees one from the others. And actually, this is exactly the purpose of it. If you are on the venous wall with one of the two windows, actually, you will aspirate only from the other window. So, no problem in this situation. If you have one window occluded, the other one will compensate. Actually, again, we have to avoid to have both vessel walls on both windows. In that case, where you don't have actually enough fluid, you may have some problem. But if you don't have the vein collapsed completely on the catheter, you will always have one of the two windows free, which will make the aspiration.
Yeah, this is a nice question and interesting point, because the Aspirex is designed to avoid this. So very nice.
Thank you, Paolo.
Very good. So we've seen also this point. Last 2 points, of course, we know that the speed is 1 centimeter per second. But again, with the contrast, with the infusion, we have a look. If the vein is collapsing, we we go back, we give the time to the infusion to come to the vein to fill it, and then we start working back. And another point you need to take care of is the collecting bag. The collecting bag is filling with fluids, also with air, because we have a tiny hole in the back part of the catheter, so we are also aspirating some air. Again, usually we are using the 10 French catheter in the Aspirex cases, which is taking out 130 ml per minute. So the bag.
Lorenzo, can you hear us? Not so much. Lorenzo, just consider if you are hearing us that
I can feel quite.
Lorenzo, you are going away. You are freezing, and I don't have controls on the presentation.
No, I'm here.
Okay, so I think you should go back a little bit because we had some issue with the connection.
Yes, about these issues, I don't know what's going on here. It's also started raining, so it can always go bad. If you want, Sergio, I can give you remote controls so you can control it if it's going on. I don't know.
Now it's okay.
It's okay. Okay. So what I was telling is I was telling to double check for the collecting bag, which is filling with fluids and also with air. And with the 10 French Aspirex, we know that we are aspirating 130 ml per minute, so it can fill quite fast. No problem. You can change it without any problem using another bag, even from the hospital. Doesn't need to be from Straub set. Remember that what we are taking out in an Aspirex case, if we are working properly with the infusion, it's not much blood because we are taking out a lot of our infusion, so saline and contrast. Okay, so the aspect of the color of what we are taking out is a little bit less dark than what we are doing in a Rotarex case, and so there is no risk also for the patient for too much blood taken out. Okay, so also this point is really important to remind to the doctors, because sometimes they are afraid, especially if they are used to other products, are afraid about the amount of blood that we are taking out. Have a look to the collecting bag before it's exploding. Just change it in case. Let's go to the main table here in the chart, guys. We have our main indication for Aspirex, iliofemoral DVTs. We know it's our big indication. We have the central veins, and in particular the portal vein occlusion, which is really interesting, and the dialysis accesses. Maybe you remember from the Rotarex chart that here we had 3 rows, acute, subacute, and chronic age of occlusion, with some tips and tricks for all of these. Of course, for Aspirex, we just have the acute part, which means up to 14 days. Maybe we can also go a little bit further and consider 20 days, but then it's becoming something different, some subacute scenario. Sometimes we have acute on chronic scenario, so acute symptom with some acute component of the thrombus on a chronic disease, more, let's say, older disease. We can face this kind of thing, but there must be an acute component if we want to use Aspirex, sorry. Iliofemoral DVTs. Here at the point, we know it's our main indication, good inflow and good outflow. Sergio was pointing out before that sometimes we don't want, in any case, to have a good aesthetic result. We need to have a good functional result, means fast flow, fast contrast when we are doing the final angiogram. And so good inflow, it means removing all the occlusive material. Good outflow, it means solving the reason for the occlusion, which in most of the cases can be a May-Turner compression. Okay. It's important to remember that we have some point of compression, so May-Turner for sure, which is easy to remember, also easy to see, but also we have the ligament, inguinal ligament, which is running very close past the vein and can compress. Even there, we can have a tight compression. So never force the catheter when we are working in these points. Here, for example, as you can see from these couple of videos, we are working with Aspirex, advancing. Probably here, from what I can see, maybe we have some more chronic component here. You see that Aspirex is just creating a channel as big as the catheter itself, is not removing all the material. So maybe we have some chronicity there. And then let's listen to the sound here. here, when the noise was changing, remember that the ligament is more or less here in this area. So this changing of sound means that Aspirex is facing some strong material, some stenosis, maybe with some fibrotic component there. So what happened is that we have a real life feedback from the system. The changing of the noise is really real life feedback. What to do here? Second passage, maybe an angioplasty. Even yesterday we were discussing, Dr. Freitas and Dr. Mia were presenting their experience with this kind of situation. What you can do is to, of course, stop the catheter, going back, maybe allowing the infusion to come in order to fill a little bit the vein. Try maybe to advance very slowly, but as soon as the noise is changing again, it means that we have a tight stenosis. It's pointless to go there with Aspirex. The problem won't be solved by Aspirex itself, so it's better to go for an angioplasty or for stenting to solve this compression, and then we go back working with Aspirex. If not, if we force Aspirex in this situation, what we can have an injury to the vessel. Again, yesterday, there was a good point stated by Dr. Freitas and Dr. Migliara, that in veins, it's not that common to have a dissection. Why? Because of the vein itself. The vein wall is different from the arterial one. The arterial one has more layers, more structure, more powerful than the vein. In veins, usually you don't do a dissection. Usually you do an injury, like in this situation. So a rupture of the vein. It's more common than having a dissection. Do we need to panic in this situation? The answer is not. We can solve it with an angioplasty in most of the cases, usually. And again, Sergio was pointing out something really interesting this morning. We need to set our mind in a different way when we are treating an artery and when we are treating a vein. When we are treating an artery, we want to avoid to put too much stents. We know that we have reocclusion very high with stents. We have some area that are the free stenting zone, like for example, the popliteal artery, because of the bending. We want to avoid. In veins, on the other hand, we need to take care of all the chronic component. We can put stent without any problem, long stent, big stents, in order to solve the disease, in order to have a good result, which again, it's the fast flow. So don't be afraid also to put a stent there, to go also under the ligament, which is something that sometimes someone is not so keen to do. Don't worry, place a stent, dedicated venous stents, which is really important, and you will have a good result at the end. It is important to leave the vein patent at the end of the procedure. Do you want to add something, Sergio, about this? You were explaining perfectly this morning.
Yeah, perfect. From your side, really important take-home message, a low-pressure system, so don't be afraid about perforation. And anyway, the chronic part of the lesion has to be treated with a stent. So even if you don't solve, this issue with an angioplasty, you will anyway have to put a stent. So no worries. We are in a different scenario compared to arteries.
Go big or go home, as they said yesterday.
Go long or go nowhere.
Exactly. Very well. Going back to our chart, we have the central veins and the portal veins. If someone of you attended the first NESTS webinar a week ago, and we had a very nice presentation from Dr. Thomas Heller explaining his experience with the portal vein thrombose solved with Aspirex. Portal vein, it always took me a while to understand how it works. And I tried to study it using this website. It's called biodigital.com. It's free. You can go there. You can have all the anatomy, arterial, venous. You have everything else, not only arteries and veins, vessel. You have every organ of the human body. It's really interesting. And so to me, it was not that clear. So I wanted to understand it a bit better. So we have veins coming from the organs of the abdomen, from the stomach, for example, which are coming here. And as you can see here, there is no connection between the portal system. This is the beginning of the portal system. Then we will see the portal veins. There is no connection between the portal system, and this is, of course, the vena cava, the big vein here, going back to the heart. No connection at all here. Here we have the portal veins that are extending where they are going. They are going into the liver, as you can see here. So no direct connection with the vena cava, but they are going inside the liver. And then what happens? That inside the liver, we have other veins that are the hepatic veins, which, as you can see, are directly connected, you can see from this image, with the vena cava, okay? And again, they are taking blood from the liver, going back towards the heart, okay? So the question from my side, at least, was, okay, how can I access a system which is not directly connected to the vena cava? And we have an organ in between, we have the liver in between. Not that easy, at least for me. So here I have a video which is explaining a little bit one of the two approaches we can have. We can have a transhepatic approach. It means puncturing straight from the liver. This is one option. And then we can have this transjugular, trans-tips approach. Tips, which means, I need to read it, so let's wait for this video to start. It's a transjugular intrahepatic portosystemic shunt. It's it's creating a shunt in order to lower the hypertension that someone can have in the liver, okay? So this video is not strictly related with our procedures, but it's the same that we can do in order to access the portal vein system. So here you see more or less the same scenario, same anatomy that we have the stomach, the liver. And as you can see, we can have a transjugular approach, a normal puncture, the same that we do, for example, to place Capturex when we are using Capturex in our procedures. And of course, here, from what we see before, we can access the hepatic veins quite easily, I would say, from this video. So, because there is a connection. And then what's happening? Here, when we are inside the hepatic vein, they puncture with a needle. Now it's coming exactly, and they are going out, and they are reaching the portal vein through the liver. So now in this video, you will see that they are placing a shunt. They are creating this connection between the hepatic veins and the portal vein system. What we do in our procedure is that here we are advancing the introducer sheath over a guide wire, and then we have access to the portal veins. So I hope this can clarify a little bit how to have access to these veins if we have an occlusion there. Keep in mind, as you maybe have seen here, we don't have so much landing zone, especially here. So for the guide wire, keep in mind to have double attention to the guide wire, where to place it. Maybe we are working close with the catheter head, so you maybe want to ask your second operator to pay extra attention to take and to secure the guide wire in the correct position. Otherwise, we can have the guide wire aspirated from the catheter itself. So I hope that with these couple of videos, it's a little bit clear the situation. It helped a lot for me to understand what they do to solve these occlusions in the portal veins. Last indication, but of course it's really important, not least, the dialysis accesses. When we treat dialysis access, we always recommend to treat, if we are talking about fistula, mature fistulas, it means 2 or 3 months old fistulas. So that the vein, went to the gym with the arterial pressure that is facing when anastomosis, the fistula is created, and so it's strong enough for the Aspirex, for the aspiration power that needs to face. Usually in dialysis access, we have 2 components. We have a stenosis somewhere, which is the origin and the reason of the occlusion, and we need to solve it at the end with a PTA or with a stent. But in most of the cases, we also have an aneurysmatic part of the vein. When we have an aneurysmatic part, can be quite big, and so Aspirex cannot be enough to aspirate everything. What we can do is using the ultrasound probe to gently compress this aneurysmatic part in order to make a little bit smaller this aneurysm, and then to treat everything. If we have a graft, we know that we always go with Rotrex. It's the same of treating a bypass, same of treating a liver leg, no difference. What kind of approach do we have here? A lot of approaches we have in treatment of the dialysis access. From the arterial side, which can come from the femoral or the brachial way. Pay attention to the angle here, can be steep. The 4 centimeter rule circle that you can, diameter that you can draw here, it's always valid. It's the same of the bifurcation of the iliacs. So if too much steep, keep in mind this aspect. Radial access is commonly done. Radial is a small vessel. Just keep in mind that sometimes if you want to go with a big catheter, it can be too small, just this one. Venous side, we can have a retrograde puncture, an antegrade puncture, depending on where the occlusion is, close to the anastomosis, far from the anastomosis. But what we can see most commonly used is the double puncture, okay? So never go with a double puncture with a cross-introducer sheath, because otherwise you will leave this part not treated. So don't go this way. Go this way with a double puncture, and remember, always start cleaning and aspirating on the venous side, okay? And then on the arterial one. Why? Because if we start from the arterial one, then we can have distal embolization quite easily, because here we have high pressure, we clean here, and then the distal part can be embolized. So first we clean the venous side, we leave this cap, and then we clean this proximal cap. If we have a graft, we can go with the apex technique, puncture, we clean venous side first, arterial side, then moving the introducer sheath without any problem. Okay, guys, so we are treating, and we are almost at the end, I promise, we are treating an acute occlusions, so we always need to keep in mind that we want to avoid distal embolization. All the rules that yes? I cannot hear.
We have a very, I think, good question from our audience about contrast in fistulas.
Yes.
It's always, I think, a little bit tricky if we have to infuse, not infuse, if we have to use contrast, only saline. What do you think, Lorenzo?
From my experience, what I can tell is we need to be sure that we have at least some flow in the catheter. Otherwise, we know that we can have some trouble. So my suggestion is to gently infusing anyway. In this situation, I would pay extra attention to how fast is the infusion in order to be a little bit more gentle with the infusion in order to avoid to push material down, especially in the distal part when, just few centimeters in the venous side are there. Be gentle. Maybe you can a little bit, take the speed of the infusion down in order to avoid pushing something away. My suggestion with the contrast, it's always better to see what we are doing. So again, having the contrast is always an advantage. If I want to be sure to be 100%, you can go there. Keep in mind that if you are using the ultrasound probe, you also can see from there how the catheter is behaving and if the vein is collapsing or not. So maybe sometimes using an ultrasound probe can avoid you to put contrast in the infusion as just saline. Again, you have to balance a little bit. I don't know, Sergio, if you want to add something about this
or
point.
Umit, maybe.
As
would you like to add something?
It's okay. Lorenzo already explained entirely.
Yeah. And I think, the most important part, we are talking generally about dialysis access, but as you showed, there are many, many different approaches. For sure, for example, I would not use contrast if I'm, or at least I would be cautious in it if I'm approaching the lesion from the arterial side, for example.
Sure.
We know that arterial pressure will, bring this contrast away from us. Different is if we are, for example, puncturing inside the thrombus, no problem with infusion. Again, gentle to avoid pushing this contrast in the arterial side, in the brachial artery, for example, because the embolization at the hand level can be very dangerous. Nevertheless, these patients, are under dialysis. So for sure, we will not create damage to the kidneys. But, be balanced, I would say. This is the take-home message. If you are putting contrast, is okay. It will, make the procedure easier. For sure, pay attention because you are normally working either with a 6 or 8 French. So you are normally aspirating 45 or 75 ml per minute. So you cannot give fast drops to your infusion. This would be too much for the catheter to take out all that material. So gentle drop by drop infusion is okay. Otherwise, probably we will not have liquids in the catheter, but pay attention to it, I would say.
Yeah. True, and flow. We know that it's really important for our catheter. So some way we need to provide some flow to the catheter. Otherwise, we can have some problems. Regarding distal embolization, we were talking about this also in the last topic. Everything that we said for Rotarex is still true also for Aspirex. So keeping the motor running, for sure, it's helping us avoiding distal embolization. Moving slowly, in particular in the distal part, pulling back the catheter with the motor on, it helps a lot. Keep in mind that we rely a lot on the aspiration of Aspirex. We know it's really effective. We also know that in some cases, for example, iliofemoral DVTs, when we have the mid-tunnel compression, it can be a natural filter. So we don't recommend to use a filter every time we are doing our cases. But when we have free-floating thrombus in the inferior vena cava, when we have thrombus protruding in the inferior vena cava, always put a filter. If there is any potential risk of pulmonary embolism, put a filter. If the doctor is not feeling confident to go without a filter, just can put a filter without any problem. And of course, if they put Capturex, we are even more happy. And we know that Capturex is the best filter that you can have. And so this is the recommendation.
Also, the patient will be more happy.
Exactly. Of
Put
course.
it in, take it out in the same session. No risk to have it there for 6 months. Longer filter stays in the body, more the adverse events that the patient can undergo. And
sometimes they cannot even retrieve the filter anymore, and they are there causing a lot of damages. Yeah. And we talked a little bit about flow, always in flow, really important. We know it. We already talked about the infusion. It's really the successful key for a very good procedure. And so here, your best friend is your second operator. So the best second operator we can have is a second operator like this doctor here, which is not even looking at the angio screen, just looking at the collecting bed, squeezing the tube every 3, 4, 5 seconds, looking at the column of blood going up. This is a 6 French. You can maybe see the green color here. Here on the other video, we have the 8 French catheter. You can see that the speed of the column of blood is different. The aspiration capacity is almost double in the 8 French compared to the 6 French. It's almost double in the 10 French compared to the 8 French. So doctors, they need to understand what to expect. They need to see that the column, especially in the 10 French, is really going up fast when they're closing it. So they need to expect a fast increase of the column of blood going up. And another important point is that they need to expect a color which is not that dark. Why? Because we have blood mixed with our infusion. If in an Aspirex case you have the color coming out in the collecting bag which is too dark, it means that the infusion is going somewhere else. So maybe it means collaterals, maybe the infusion line is not open. Sometimes it happens before starting. We know that we need to provide infusion close to the catheter head, so long introducer sheath, very close to the catheter head, and again, it's important to tell the second operator because he needs to know what to expect. Then here, the second operator is securing the guide wire as this one, but he did a couple of things more. So he placed the torquer that we have inside our set of the guide wire over the guide wire here, a few centimeters, 10 centimeters from the end of the catheter itself. This is a visual feedback if the guide wire is moving together with the catheter or if it's steady and stable without moving. So this is a visual feedback, really easy to be seen. And then he also put this gauze at the end of the guide wire. Again, you can just have a quick look at this and you see if the guide wire is moving distal or maybe it's coming back, just looking at the end of the guide wire, if it's still there on the gauze or if it's somewhere 15 centimeters back or 15 centimeters in advance. Again, it's something that it takes 1 second to place it on the sterile table, but it helps you a lot in the procedure. If you are supporting a case, you can also have a look, really easy to check, instead of asking maybe many times to the doctor, is it the guide wire in place? Is it far away from the head of the catheter? You will have a visual feedback. You don't need to ask anyone. You know, we have other things to take care of, correct movement, the flow, and other stuff. So at least the guide wire, we can see that it is in place. We know do not activate the motor in dry condition without the guide wire. Again, the risk of breaking, especially the big catheters, is really, really high. So flush the catheter with saline, put the guide wire on for all the length, and then again in the bowl of saline. And always start the motor in the open proximal vessel to avoid compromising the aspiration. If we start inside the occlusion, we will have an overload of thrombus to the catheter head, no flow at all. Remember, the fragmentation of Aspirex is less powerful than Rotarex. We will have the same problem with Rotarex, which is more powerful. Imagine with Aspirex, which has a fragmentation less powerful, so bigger thrombus taken inside. This is true every time we stop the motor. So at the beginning of the procedure, open vessel. If we are moving inside the occlusion and then for some reason the doctor needs to stop the motor, remember, make them move 2 centimeters or even more if the open vessel is even more distant from there, because if you reactivate the motor immediately where they stopped, you will have a potential blocked catheter because, again, overload of thrombus in the catheter. That's it from the presentation. What tools do you have for going to your doctors? You know that we have our dedicated easy way video for Aspirex. We have the one for Rotarex, the one for Aspirex with the preparation of the infusion mix. This video has been speed up a little bit. Usually it's a little bit slower to prepare the bag of saline and contrast before the case. So it's always better to have it prepared in advance, to put in a pressure cuff. You don't want to wait maybe 10 minutes in order to prepare the bag when the patient is already with the access done, with the Aspirex ready to go. Make sure that the nurse, chief nurse or nurse which is taking care of it already prepared it and it's ready to go when the doctor is ready to start the aspiration. And then you have all the, here you can also infuse 1000 heparin at the beginning through the side port of introducer sheath. This is not adding anything to the systemic heparinization, it's just softening a little bit the thrombus in the proximal part. And then you have all the steps, flushing the catheter, putting it on the guide wire. Second operator is showing that is compressing the collecting bag, as you can see, and everything is available for you. If you don't have it, this version, which is the updated one, write to webinar@straubmedical.com. If you want to have it, you can write or text your area sales manager, and you can ask for that. Then we have our strategy form. Try to fill it with as much information as you can in advance. Okay, when we are talking about the Rotarex case and arterial one, maybe also 1 week in advance. Aspirex case, we know that are not planned so in advance, but at least a couple of days of notice, 1 day of notice you have, and you try to ask as many questions as possible to the doctors in order to be prepared when we go in the cath lab. And then we have our checklist just before starting. Really fast, you can just tick these boxes to double check if everything is ready, everything has been done. We can go for the procedure.
Great, Lorenzo. Great. Very, very, very well done. Guys, I would suggest, I would say we promote everybody as panelists so we can have last few minutes Q&A session. In the meanwhile, guys, a couple of take-home messages from you and from Umit. Umit, do you want to start?
Yeah, for the Aspirex, I would like to tell, always fresh our aim, but sometimes suddenly we pass the lesion and collapsing. If we always check the inflow from the catheter.
Perfect. Flow, very important.
Flow, yes, always flow.
From my side, I think that the take-home message here is that it's important, again, not to look in this situation somewhere, because it's really important that this vein remains patent for a long time to avoid post-thrombotic syndrome and other adverse events. And the second take-home message is to have always the right tools to do all the procedure. It is just not Aspirex. It's the long introducer sheath, the 1 French or 2 French big introducer sheath, no problem in puncturing in the popliteal vein with a big introducer sheath, dedicated stents, high pressure balloons. We need to have the full set in the cath lab. So make sure that before starting a procedure, you check the warehouse, just looking and seeing which kind of venous stents they have, which kind of balloons they have, because we need to finish the procedure in a complete way. It's not just that we are taking out thrombus and that's it. Otherwise, after a few months, maybe the patient can have another DVT, and so again, we need to go back there.
Exactly. Actually, to resume what you said, strategy is very important to plan in advance the case, have everything there, everything that you may need. And, we do have a single session device, a device which will treat our patients only in one single session. So we need to allow to Aspirex to do his job by having everything we may need for the procedure available in the cath lab. So guys, please feel free to unmute yourself and, ask your questions if something is not completely clean. As Lorenzo was saying, main target for today is to go home having all your doubts cleared when you are treating and supporting an Aspirex case. So feel free really to ask questions, or I'm sure that your doctor made to you questions that were really difficult, you struggle a little bit to answer. Maybe you can share those questions with us and maybe we can find a possible answer to this. I don't know, guys.
Sergio, I just scrolling the chat and I see, after how long do you consider the fistula is mature?
Okay,
so
very good question.
Yeah, it's a good question. So then, Umit, Sergio, you can correct me. Usually it's a period in between 2 and 3 months, usually, no? What do you think?
I would say so. Consider that, it's true that if a fistula is occluded, even though it's not mature, so actually didn't work as a fistula yet, probably there is no point to reopen it, because probably this is a surgical defect in making the fistula. consider that Aspirex can also work in normal veins. You need to have a very arterialized fistula if you want to consider, for example, the use of Rotarex. Exactly. You can treat even not mature fistula, but normally the vascular surgeon will tell you, why should I treat something which never worked, because probably has been done not in the perfect way, but by another they would normally do surgeon. So in this case, probably
we can tell that you have a lot of experience, Sergio, in this field, because you also know how they talk.
Exactly. So in that case, probably they would prefer to make a new fistula, but yes, 3 months more or less is what we normally consider a good arterialization.
For me, it's not even enough 3 months of gym to build the muscles, but for the vein, it's enough, because the arterial pressure is training the vein, and it's 3 months.
But it's an extensive training, 24 hours a day, 7 days a week.
So there is hope also.
Sergio.
Ciao, Paolo.
Sergio, how are you? Everything's fine?
Fine. And you, my friend?
Great. I'm always good, man. Always good. I got a question for you. I have a doctor here. He usually makes fistulas, but he never uses Aspirex. He always uses Rotarex for the fistulas, 6 French. Usually these fistulas are all arterialized, usually. And he never used Aspirex before, always Rotarex 6 French. Is it right?
I would say so. And then
we have had success, okay?
Yeah. In my opinion, yes. Actually, we do have experience on use of Rotarex in dialysis access in fistulas, because we well know that in grafts, in dialysis grafts, Rotarex is the correct choice. But we do have experience also in fistula with Rotarex. Actually, they have to be well arterialized. It's a pretty straight path, so I would say that is safe. Nevertheless, we also had some problems with Rotarex. Sometimes in fistula you can have residual valves in the vein, and if you grab those valves with a rotating head of Rotarex, you may damage the fistula. So is a treatment I would only recommend for well-experienced doctors, maybe under ultrasound guidance, where you can, I would say, see the valves if they are present, and you can stop the motor at the level of the valve. But, one of the big issues with fistula is that more residual thrombus you leave in the fistulas, more these fistulas will occlude. So actually, the use of Rotarex will allow much longer patency for the fistulas. But I think it's correct. I would not suggest the doctor to start with Rotarex in fistulas, but if he's an experienced one, I think he did the correct choice. What do you think, guys?
Oh yeah, I agree. For sure, not first case not to start with Rotarex if they never use it. When they do some cases, they understand how it works and they know the potential risk that Sergio explained properly. They can also go for Rotarex, but they know what to expect. And so this is why.
Exactly. Explain the potential risk. There is a potential risk for this, but normally experienced doctors also can, manage eventual complications.
So I should always indicate Aspirex and fistulas then. Yes.
For the first treatment, yes, I would say so. For, after 4 or 5 cases, if you explain the risk, they for sure will know that, more thrombus they will take out, longer will be the patency. So if they know the risk and they know the benefit, I think they can balance a little bit and decide. Consider that, in case of rupture, normally they may just,
Sorry, I can't hear you. It's failing.
Okay. No, I think the connection should be pretty good. Normally if a rupture occurs, they can place a stent, actually a Viaband, for example, and they can use it, a short one only at the area of the perforation. Maybe somebody. Thank you for the question.
Nice question.
Umit, do you want to add something?
Yeah, for the Rotarex, the needs some experience to use for especially the fistula, and because there's some parts when you are passing, you should be very careful. You should listen well. So I also recommend start Aspirex, then Rotarex. Recommended like that.
Okay, some comments from the audience. Some more questions. Okay, guys, I think that's it. Lorenzo, please.
So, guys, thank you very much for being here. Thank you, Sergio and Umit, for supporting me. And again, I'm sorry for the connection problems. And hopefully it was just a small, incident.
All in the clouds.
Exactly. I would like to thank you, our audience. I've seen that they were interacting a lot via chat, so thank you very much. And maybe I just remind the appointment for next week, as we have a very busy week. So next Tuesday, and you should have received the email, the 5th of May. We will have our second next webinar series. For the webinar series, it will be the Do the Math one. So we are going to explore a little bit the world of Rotarex. We will have Dr. Migliaia, Dr. Sven Braulik, and Dr. Isernia from Perugia together with us. Dr. Sven Braulik probably is the doctor who used most Rotarex and Aspirex all over the world, so huge experience. We are going through stent, bypass, EVAR occlusions. It's open to you guys, to all of the doctors, so spread the voice. You have the newsletter with you. Register, and we will see you on Tuesday afternoon for us.
Think about the Sven Brownlee. He's always alone in front
the
of the
catheter. Yes,
he probably touched more catheters than the ladies in our production.
Yes,
so very
it's incredible. Yes. Then on Thursday, the 7th. Again, in the afternoon for us, on the western part of the world, we have, in Europe, let's say, we have a webinar, which is, we are just a small part of the webinar, but it is really interesting. Maybe, Sergio, you want to explain a little bit what's about?
No option CLTI patients. There are some patients that you cannot treat. You cannot open the tibial vessel because there is nothing below the knee. And actually, this patient recently are treated with deep foot vein arterialization. So they make a shunt, they create a fistula between the last part, the proximal part of the anterior tibial or the posterior tibial, and they connect it with the vein through a Viaband, through a cover stent. And then they go down till the 5th, they devalve the vein so that the blood can get into the foot through this arterialization. This is a technique, actually, we are not treating with Rotarex, and we are not doing anything with this technique, but sometimes the Viaband occludes, and so you have to open the Viaband, and the best way to do that is using Rotarex. So we are hosting this very interesting event. Consider that it's promoted by Dr. Migliara, very good key opinion leader for us, and I think you heard about Marco Manzi. He will moderate the session. So already a busy session, already probably, our record 280 subscription until now. But we have plenty of space for you, for your doctors, so feel free to attend it, but please register as soon as you can.
Exactly. And then, last but not least, on Friday, so the 8th of May, we will have live cases from Arnsberg with Dr. Lichtenberg. Still, we are collecting some details, so the time is not clear yet, but you will get our usual newsletter about it. Again, spread the voice. Invite also your doctors who can be interested. You know, we cannot travel now, so it's impossible to organize physical workshop. This is a good way, you know, to see live cases, good procedures, interesting procedures, listening to the expert voice, key opinion leaders around the world. So as many as we are, we will have more fun, and yeah, we wait for you.
If we did not receive the invitation, just let us know. But for example, for Lichtenberg's one, we will have to wait until middle of next week.
Yes, exactly. Good. Okay, I think that we can close it. Thank you, everyone, again, and I hope to see you soon. Ciao, ciao.
Ciao, guys. See you next week. Ciao, ciao.